Okay, can everybody see the screen?
Yes.
Okay, so I was thinking about, like, what are we going to talk about? And every time we talk about documentation and coding, and now that we're getting into our crunch time, I thought maybe we should talk about some of the things that the practices can do to see where they're at, and what they can do as far as missed opportunities to get your people in the practice, get their MRAs documented, because whether everybody realizes it or not, you have about 40 to 45 business days till the end of the year. So I'm sharing with you, I decided to go into Blue Sky, and let me just first say that I promised Derek that I would tell everybody that this is a demo site. This is not live data. I am not making any HIPAA violations. I just wanted to go through here and to just make sure that everybody realized how you can utilize the HCC reporting within your Blue Sky for your crunch time. So I have up here the demo site, and I just want to go through it a little bit. I actually am going, I'm on your, if you were to log into your Blue Sky, your HCC Insights, there's a report in there that's actually very good. I would suggest that you have your office managers or your administrators run this report. Again, this is all demo data. This is not live data. So what I did was I just filtered on a provider. You ask for the target year, and you can do your report by HCC or by member. But right now I chose it by HCC. So this report is actually going to tell me for Dr. Abrantes all of the conditions that were reported last year in 2019, but have not been reported in 2020. And it's going to show you what you're losing as far as your risk scores. So this will give you a snapshot of where you're falling out and what you can do as far as opportunity for the rest of the year. When I look at this, I kind of go to my best bang for my buck and look at like some of your diabetics with chronic complications. Here you can see that 59 are falling off, which should never fall off. Diabetes is a condition that does not go away. You can click on the 18 category. It will show you every patient that diabetes has not been reported in that practice for 2020. I would then give this to my front office girl, and I'd have her start calling for appointments. Because otherwise, if they're not in, you can see their last date was in 2019. If you don't get it reported before the end of the year, you're going to lose that score. So I kind of use this as a guide. It's a summary, but go through it. Some of these are conditions like your cancers. Typically those are things that could drop off. So I go through it and I make sure all the ones that really should never drop off, I'm hitting first. This way you can start to get them in, and get them scheduled, whether it's a face-to-face visit. If you're still having a hard time, get that video visit for the telehealth in. It will still count towards your MRA. You can also run this by member. Again, not live data, but you can see it gives you that all the patients within that practice that are potentially have dropped HCCs or risk adjustment for 2020. This is your last 45 days to recoup that score. So for example, after you go through it, and if your front desk gets, like, say for example, they were able to get Benjamin Asher scheduled. So I would have this open at all times so that when his appointment comes and he comes in, you can actually see, click on him and see every condition that was reported in the past in 2019 that has not been reported in 2020. Now for us up here in Florida, I would have my front girl, when Mr. Asher's appointment is coming up, I would have her start documenting, either say in the shell of a note in a chief complaint, list all of these, put them in the assessment, somehow alert the provider, this member's coming in, this is your last opportunity, these are the conditions you need to discuss. It's just such a helpful tool. It gives you the category that you potentially could lose, and some of them you should lose. I would say this atherosclerosis with the ulceration probably has healed since August of 2019. Maybe, maybe not. But your diabetic with complications still exists. The malnutrition, maybe, maybe not. The necrosis, you know, some of those, if he had the replacement, if he didn't, you know, go through it, but at least you can see, you know, where you can still have the opportunity to document those conditions and maintain your score.
So let me ask one question from the audience. Is anybody doing this currently in their practice? Because I'm sure I'm not doing it in my practice.
Yeah, you really need to make sure that as of like November 1st, you know where you're at and what you have left to do. And this is a great tool. I mean, if you run this by provider, which all you have to do is drop down, select your own name, go into your live doctor's ACO data, select Dr. Aggarwal, you can click on HCCs, and like I said, sometimes I go through this and I look, okay, what HCCs should I never lose? And then I look for, where do I get the biggest bang for my buck? Okay, so I would look at ones that typically never fall off, are never cured, and have the highest risk scores. And then I would drill down to who those patients are. I would have your front office staff schedule those appointments and be, you know, pretty forceful. You know, it's the end of the year. You really need to get in. You know, we have a lot of things that we need to go over. We need to make sure, you know, that, you know, that we've addressed all your conditions. And then once that appointment is made, I would also have the front girl desk either print the detail page at the member level. You know, some providers like it in print when they see the patient, but I would print then this page and either type it or copy it into the chief complaint or the assessment for the day of the appointment, so the doctor's aware of what he needs to address. Or I would simply print the page and hand them the piece of paper, say these are the conditions that you need to discuss with the patient today. But by all means, by November 1st, everybody should know, you know, how much they have left to do, and then prioritize it based on, you know, the highest scores that you're losing for conditions that never drop off. And then you have to look at, you know, the biggest bang for your buck, which patients are more easily to get into the office. Because some of these patients you'll just never get in. That's what happens. So I always look for the patients that, you know, I can coerce to get in the office and at least get these done. This will save you from losing your MRA scores from last year to this year. But at this point in the game, I mean, that's what you want to do. You know, 2021, you know, that's your opportunity to start to dive into your charts and all your documents and look for potential new MRA conditions. But right now, as of November 1st, you want to make sure you're not losing anything. So it's a great tool, and I was not sure if anybody was using it, and I just wanted to point it out, but really just stress that now is the time that you need to know and really focus on what you can still recoup from last year.
So David, can I ask you, do the Care Tracker have this drop SCC coding?
No, right now, this is delivered to the practices on paper.
Okay.
But I do want to comment is this is like the perfect ACO report. So I can't overstate how Carrie and her team is way more resources than the ACO has. It might be 4 or 5 times as much resources, but the drop to HCC is so easy. It basically, you look at your patient, you see what codes were billed last year. If you agree with adding it to your assessment and you can comment on the plan, you can add 2 or 3 codes per patient. Many of the practices, they just add it to the notes, and then the MA brings it in on the next visit. And then if you agree with it in your assessment and plan, you're golden. So it's like the perfect amount of effort. You know, it only takes you a couple minutes, and you can pick up a lot of MRA score.
Yeah. Now, and I'm sorry, David, it was my understanding, I talked to Derek today, that these reports were available to the ACO doctors.
They are. So we have a tool called Care Tracker where you basically, it's a little bit easier to work, and you can report on it. It doesn't have all the reports yet.
Oh, I'm sorry. So then I was unaware when I asked him, and he said, yes, these were available. So, but if you deliver them, I mean, it's the same concept. Look at what, you know, what you haven't done from 19 to 20, and, you know, make your last ditch effort to get those patients in and get it documented. And of course, you also need to have the support. You also need to have your treatment plan and your current status. You can't just list them in the assessment. But you know, the main goal is to, by November 1st, every provider should know where they're at and what they need to do for the rest of the year. You need to start making a plan of action. You only have about 40 to 45 business days left to get these patients in.
So the question on the chat, Kerry or David, you can answer that.
Let's see. No, you cannot add HCCs to nursing visits. It has to be a face-to-face visit with the provider, which would be a physician or physician extender.
So the question here is, how current is the SCC data in Blue Sky? Is it 3 months old or more?
That would be a David question, maybe?
The Part B is 45 days old.
Okay.
And then, Carrie, I think you can add HCC to a 99211, correct?
No, you cannot.
They skip that code?
It's a nurse visit only, and HCCs are only with qualified physicians. So that CPT code does not qualify for HCC reporting.
Okay. I think so you'll want to bill a 99212 or more. Correct. To get the HCCs. Got it.
And it has to be a provider or a nurse practitioner or physician assistant. If those credentials are not on the progress note, it's not a qualified visit.
Good. So Kerry, what else you have?
That was about it. I really just wanted to make sure that you know, everybody is aware of that. You know, this is their last opportunity to, you know, organize who they've seen, who they haven't seen, and developing a plan on getting those last patients in and documenting at least what was documented in 2019. Because while you do have that 3% that you can grow, you certainly don't want to regress. You want to at least document everything in 20 that you had in 19. You don't want to lose. So this is your last opportunity to get those patients in, and it really should be a priority focus in the office for this segment of population.
So thank you, Kerry. I mean, this is awesome. This is new information for me. So tomorrow I'm gonna collect all my people and say, listen, let's do it. Let's.
Yeah,
so I invite all of the physicians, not even ACO, from Doctors ACO and New Jersey ACO, anybody else. This is something we available in Blue Sky. And so almost New Jersey ACO has Blue Sky, Doctors ACO have Blue Sky. So please at least use that. That will really can change the difference in your saving in 2020.
Yeah,
So-
definitely. And you know, look at those lists and prioritize. If you know, there'll be people on that list that have not been seen in 2020, but if they don't have any reportable, you know, MRA scores, they're not your priority. Well, you know, they may be your priority for other reasons, but for risk adjustment purposes, they're not your priority. Your priority are the people that have not been in 2020, who have risk scores, and then who have high risk scores that you need to get in.
Very good. Thank you, Carrie. Appreciate that. And maybe we'll bring something new next in 2 weeks. David, I would like you to make sure that everybody knows that doctors, ACO, physician, and their staff member will be awarded to attending this meeting and the future meetings. So the next section is headed by David. David want to tell us what we can do in the crunch time for ACO, how to create a 6 million saving to a 10 million saving. And this presentation was available last, but it was not very clear. So I invited again David, and then other people can chip in. Please ask questions and get involved in this. I think we believe that with individual help from physician and physician staff, any ACO can significantly improve in next 70 days. So David, take it from here, and please ask questions and get involved in this discussion.
Yes, sir. Carrie, can you check my answer to the question about getting HCC from specialists and hospitalizations? Do you agree with that?
I'm sorry, let me check it. Correct. You are absolutely correct. While the specialists may bill, or you know, from the hospital or their office, they may bill the MRA condition, and you do get credit. You know, if they don't continually see that specialist each and every year, you will lose it. I always tell the primary cares that you are the gatekeeper. You are the manager of that patient's overall health care. You should be the one responsible for reporting all of their chronic conditions. You don't have to be treating them, but you should be reporting them, because if you're relying on a specialist for your revenue, and that's never a good thing.
Thank you. So I'll go into crunch time. So the goal is that Doctors ACO is going to get a $10 million check in 2020, and we can absolutely do it. So you may think that because it's a pandemic that the government won't pay you. Remember, the government, the politicians, they're all bragging about how great the stimulus is. They don't want to pay you less money. They want to pay you more. And they believe that the ACO payments are going to the highest quality physicians, and they want them to be healthy. When I meet with Medicare, when I meet with the trade groups, the 2020 payments are expected to be higher, not lower. Another thing is the government's trying to give you the benefit of the doubt. So if it's a COVID-related admission, Medicare will take all expenses for that month as well as the following month. Now, there's a trick, is if the admission is on the 30th and it ends on the 3rd, okay, Medicare will take all of the first month from the 30th, they will take all of the second month from the 3rd, and then they will take the 3rd month. So Medicare is trying to make it fair for you by taking out some of these unexpected expenses. So this is definitely going to be a great year. So if Doctors ACO, if the game was over right now in the 3rd quarter, you would receive a check of $5.6 million. But as you're all aware, most of our ACOs, they rock the 4th quarter just like the Bulldogs. So this is your opportunity. I've seen several ACOs double, 100% increase their shared savings in Q4. 2020 should be no exception. So what's our plan? You know, we can have a complicated message, but why do that? Let's have a simple message. So the plan to finish the year is to maximize your office-based patient management. So independent PCPs are the best in the world at managing their patients in the office. Let's do that. And then Your ACOs also have the outreach program, which is a comprehensive home visit program. The key here is the outreach program is for your patients that you can't manage in the office. So, you know, if these patients are chronically ill and it's beyond your scope of practice and they need more visits at home than they can get in your office, please refer them to outreach. They'll get the care that they need, and then every once in a while you may decide that you'll transition that patient to that other PCP. So these are the two approaches. If the patient fits into one, great. If the patient doesn't fit into one, put them in two. This is a little bit more detail, but Care Tracker is the new ACO tool. We're really lucky that Blue Sky came up with this. It's a very efficient way to manage your patients in the office, make sure none slip through the cracks, keep your staff very efficient. And then I already talked about outreach. If we execute on these two items, there's no reason why we can't get to 10 million. All right, so Care Tracker. And then for those of you in New Jersey, I understand Amanda's going to have Blue Sky install Care Tracker on the 15th. So I think we can bet on that. So you just have another 2 more weeks and you'll have the same thing. So what is Care Tracker? The Care Tracker is the automation of ACO reports. So the ACO is dropping off reports 2-3 times a month, right? So they're dropping off reports approximately 9 times a quarter. What Care Tracker does is it delivers all your reports at one time at the beginning of the quarter, and it's much more efficient. So if you had one patient and they were on your high cost, high risk, if they were on your ED frequent flyer, if they were on your dropped, right, you could work this patient 3 times. You could go through the patient 3 times. With Care Tracker, you only have to work them once. So potentially you're saving 75% of the work, and you're making sure you're managing your patients to get those savings. The second thing is it helps you stay organized. So we've seen these paper reports. Sometimes they go right into the round file, and the office doesn't even work them. And then we've noticed that when the office calls the patient and it's called left message, those patients are often never ever followed up again. And then you call leave message number 2, very, very low chances. So Blue Sky created this tool where anytime you call leave a message, you just put that in Care Tracker and it'll remind you to call the patient in 2 weeks. It's very mindless. You don't have to keep track of your paper. You don't have to keep track in a spreadsheet. It does it all for you. So when you mark called left message, return in 2 weeks, the patient falls off your list and they come back in exactly two weeks. What if the patient says, hey, I'm out of town, but I'd like for you to call me back in 2 days? Then what you do is you say, patient unavailable, call back in 2 days. They fall off your list and they come back in 2 days. So it's a way to make sure that absolutely no patients slip through the cracks, and it's a way to make sure that your staff is keeping up with the ACO work. So when we drop off this system, sometimes the staff, they say, oh my gosh, this is so much work. And we got to make sure we make a correction here. So does your staff want your office to be busy? That might mean it's stressful for them. That might mean that that's more work for them, but for you, that's more money. So if Care Tracker has a list of 350 patients that need to be worked, just like the ACO reports, that's $26,250 to you. So we hope that you feel like when Care Tracker comes to your office and your consultant says, hey, how are you doing on Care Tracker, that you feel like that this is not more work, but it's more money. Once again, every single patient that you work in Care Tracker, the way you work it is you schedule a visit. So that's how that translates to money. It's $135 a wellness visit, $75 an E&M code. Here's the big one, is often our physicians, they think that their staff is being more productive than they are. It's just a fact. You can't manage what you can't measure. And the great thing about Care Tracker is there's no more secrets. So this office on the left is an example of an office where we stop by and say, hey, how are you doing on your scheduling of ER frequent flyers? How are you doing on high cost, high risk? Oh, I'm doing great. Really? It shows that you've worked just a few % of your total. Oh, what I mean by great is I meant to get to it. So this is information information for you to have to make sure that everybody's working the way that they need to. No big deal if you can't do it right now. Just tell the ACO when you can work it and schedule these patients to get the revenue. The second thing is sometimes the quiet offices are the highest performing. So, this next office had done 475 actions in that week, and this is a top performer. And, maybe you can bonus your staff that are high performing. Maybe you can compliment your staff, but now you'll know exactly who's working and who's not. I will give a disclaimer is, I think Palm Beach ACO is going to part ways with one of our employees. So we have assignment specialists, and there was an irregularity with the care tracker. So, they told their manager they were scheduling a lot of appointments. Next thing you know, there was patients scheduled in care tracker, but they weren't in the EMR. And then, when we checked in the annual wellness visit report, we were wondering why there's this huge disparity. And now that we have these tools, we were able to find out that that employee wasn't nearly doing as much work as they should have been doing. So they might not be here anymore, but it could have taken us months and months for us to know that that employee was doing that. So this was really a big wake-up call. Another new thing that came out is there was a doctor's office that was starting to get on the boot camp list. So they were having trouble managing their patients, their costs were going up, and our physician leadership was asking them questions, and they weren't able to keep up with their work. So we're looking in Care Tracker, and then there were 600 actions done in one day. So there's a lot of questions that have to be answered by that physician because they were clicking off on the wrong button just to get credit. So this has really been very eye-opening. We've come to the next level by being able to manage, actually by being able to measure the work that's being done. Doctors ACO gets after it. We work 1,400 actions a week. So if you take that, that's 7,500 actions in a year. So this is how we make sure that none of the office-based patients slip through the cracks, is we manage Care Tracker religiously. And as you can see, I think this has changed since then. This is an old slide, but we can tell which offices are in good standing and which aren't. And now that our ACO is at risk, our high-performing PCPs ask, hey, is that other doctor losing me money? And unfortunately, if they're in the red, they may not be trying very hard and they could be losing you money. But now we have this information and we're able to address it. So there's two options in Doctors ACO. You can either schedule your own patients in Work Care Tracker, or you can use the support center to do it. The support center now has 2 employees, so we just hired. Now there's a bilingual call center agent as well. So if you're finding that your staff is overwhelmed and not able to handle this right now, please reach out to our team, because one way or another, we have to manage these office-based patients. We have to make sure they're being seen enough to manage their chronic conditions, and we got to make sure we're hitting the $10 million in savings. So please, if you need help scheduling these patients in your office, take this number down right here and call us. We really want to help you. Like I said, we're staffing up. So Dr. Aggarwal, we can transition to the next topic, or we can sit here and answer questions.
So I would like Brian and Rochelle and Neil, I would like you to give us some input where you've been successful and where you've not been successful. See, we are all physicians and we all have our own world. We are in a risk ACO, and if we don't listen, don't learn, and do not act, see, basically there is nothing much we can do. Is that right? So we only ask you with love and affection. So please listen to your consultant. They'll come and teach you everything. But if you don't learn, don't teach, or don't change, then we'll all going to have problems. So there are clinics who have not done anything about Care Tracker. There are clinics who are 100% on top of it, and it's amazing that how fast they can learn. And you saw that every time you work on Care Tracker, you're making money. So it's you're making money, and ACO is earning the quality data together. So Brian or Rochelle and Neil, are you able to talk or no? If you're not, then I'll talk for you.
I'm able to talk, Dr. Aggarwal. It's Rochelle.
Go ahead and tell us in your circle, which practice, not name them, but say what you had tried and which had not worked to make them use and learn Care Tracker.
So the practices that have utilized Care Tracker, they are seeing a significant difference in being able to actually schedule and conduct their annual wellness visits. Of course, at first, when they saw that first number come through, some of these practices have decent sized panels. And when I say decent size, I mean they had like 450 action items to complete. I have a few practices in particular that went through and completed these action items immediately. They were able to, see the benefit of Care Tracker, as when they were putting some of these patients into the pending, they noticed that then when these appointments were to come up, or like David mentioned, when they have a return call in 2 weeks, it then pops back into open. And so that as these practices are utilizing Care Tracker weekly or bi-weekly, they're able to get in and then follow up to make sure that these patients then are getting seen for their annual wellness visits. They're also catching patients that may not have been in for the entire year of 2020. And so Care Tracker is able to assist them in getting these patients seen for their annual wellness visit before the end of the year. Practices that have had some trouble either with login issues or just not utilizing Care Tracker, we're working towards, I'll be up in the Athens area in particular next week to actually help in person with some of this training. So, they're eager to learn it. They're eager to, find out the benefits from Care Tracker as well. But overall, the feedback that I'm getting from Care Tracker has been super positive, and I'm really, really proud of the practices in the Athens and Columbus areas for working as hard as they have been, especially, during crunch time. They're really focusing on getting their patients referred to outreach, and then also, completing their action items in Care Tracker. So I want to give a virtual high five to all of those practices, because honestly, they're working really, really hard, and I'm super, super proud of every single one of them.
No, I want to talk about who not listening to you, how we can make them listen to you.
The practices, honestly, I can't say I don't have any practices that haven't essentially listened to me. Some of them just
Brian, are you there? You send me a list where I saw a lot of practice have zero action. That's
correct. So, Dr. Aggarwal, some of the practices that have zero actions, they just need the in-person training. Some of the virtual training or the videos were a little bit harder for them to actually go through. And then there are a few practices on there as well that are actually not going to be a part of our ACO anymore. And so that's why they have zero action items. Brian is aware of who these practices are, so I'm sure he'll be able to update that list shortly. But if I do have any issues next week, of course, while I'm in-person training, I'll definitely reach out to you so that you can speak to these providers. But I wouldn't actually say that there's been any issues or any practices resisting using Care Tracker.
So Brian, are you there to defend me here? Because I really don't want to make call. I made two calls to two physicians, and they were both positive. And I think, and you sent me a list of physicians I need to call. So I was hoping that we can do something here. And now I've been talking to David, and say we are willing to spend money, like $1,000 per thing, if that practice learn the Care Tracker, use the Care Tracker effectively, and by the end of the year, effectively use all the action items. So David, can you explain a little bit more about that to me, how we can give that money, and by giving them money, we can save a lot of money?
Brian, are you on, boss? That's your show. Is Brian on? So I'll take it. Brian, jump in if you can. So Dr. Aggarwal had a great idea, is the whole ACO benefits if every doctor uses Care Tracker and they use it to its fullest. So he's offering $1,000 per practice to be paid before the end of the year if you can complete all of your actions in Care Tracker. Now, there's going to be one report that's due now, and there's going to be one report that's due in November. And then if you do the one now, you get $500. And if you do the one in November, you get another $500. But if you do the one now, you'll get the money right away. So there's no reason to wait. And then, by the way, when you work CareTrack, you're getting more business. So you're scheduling 99213s, you're scheduling annual wellness visits, and you're helping your practice revenue. So you can, just like all of our ACOs, you can finish the year strong. You can see patients to finish off the year and fill your schedules, and then you can get an extra $1,000 per practice.
Great. So we're going to, let's hopefully that will change some people's mind. I think the main reason is, we're doing same thing. We are busy and we just don't have time to learn new thing. And if we don't learn the new thing, we're just going to be there where we have been there for last 100 years. The time has come where the physicians need to start thinking that they can take the leadership role and develop a healthcare system by owning the part of the insurance company. So last meeting, Dr. Arthur Hansen mentioned what they're doing, and I just wanted to encourage people to talk a little bit about concern or whatever they feel like on this forum. So I invite all the physicians who are there available. If they ask what it'll take to become a part or owner of a Medicare Advantage insurance plan. So just imagine that last year Humana saved themselves $9 billion after paying the hospital and the doctors and the MSO, everybody else. They still saved $9 billion. So just imagine that we can start thinking like that and maybe become part of that. So stage is open. Anybody just raise your hand and then unmute yourself and talk about it. Dr. Sani, how are we doing in New Jersey? So
we are doing very well, Dr. Aggarwal.
So we want you to put the file there where the county and the physician get together and say, get united together, forget about their differences, and come to the tables and let's talk about it. See what are the risks,
Yep.
what's the benefit, and can be done or not be done, how many friends we need, how many physicians we need. So basically we need, it goes county to county. So if you have your county, we have enough physicians to take care of Medicare patients, then Medicare will give you a chance to provide the Medicare Advantage services under you.
No, we are already working on it. Of course, under your leadership and Raj and the whole team, we will do well. But it's already underway. We're already making plans. We're already getting our people ready. And we do put that seed every time we do a meeting. And we will make it happen. It's a done deal.
That's great. Dr. Parikh, come on up. Let's see if we can listen from you if you're there, and tell us that what can we do in Gwinnett County to bring that Medicare Advantage plan. Okay, Dr. Parikh is quiet. Dr. Donavali, you want to say something? Just unmute yourself and come to the forum.
Yeah, I think I'm interested in Gwinnett County.
That's great. So what we need to do is start talking to independent physician, like-minded people, and the track record of Dr. ACO and a 76% return in 2 years. And this is a better deal than anything.
Hi, Subodh.
Yes. Go ahead.
Unmute చేసుకోవాలి తెలుసా? Huh? Say something.
Go ahead.
You try to look at your phone.
Okay, that's our problem. So we need to get to basically, Dr. Hodges, you are there, I can see you. You want to talk a little bit about it? See, what's your fear of getting into it?
Yeah,
Don't
here we
worry
go.
about it. That's okay. So
Well, would this program be just like the Medicare Advantage programs?
yeah, that's correct. So you
And
instead of
who will sell this to the patient? Who would the company, the ACO company, be selling to the patients, or would the individual doctors try to sell this concept to the patient?
David, you want to take that question?
I can take that. So patients are going to come from 3 places. So the health plan will hire brokers to bring new patients to your office. So these are patients that are not seeing you currently.
Okay.
The expectation is that you are going to also convert some patients. You know, maybe they have a low quality Medicare Advantage plan, or, you know, it happens, the Medicare Advantage plan may just continue the relationship with you, and then you'll want to convert them to a high quality health plan that you're on. And then the third is we're hoping that the ACO, because it includes PCPs and specialists, that the specialists for the first time can also refer patients and get them onto the plan. And then they, of course, will need a PCP.
Okay. What happens to the pure Medicare patients?
So you can't be in pure Medicare and Medicare Advantage at the same time. So that's no problem for the ACO. There's about 4 to 7% of the patients convert to Medicare Advantage anyway. And the worst thing that happens if they convert to a plan that you're not on, and then you lose the patient. So this is a really nice concept where there's a high quality Medicare Advantage plan that you're involved in, that you're influencing, and it's a good option for the patients to convert to Medicare Advantage, usually to save money and then stay with you.
So Dr. Parikh, I see you. So tell us about, we need some leadership in Gwinnett County to get physicians together. Tell us about your views about that.
So this is Dr. Dronawal. We're implementing RPM to the patients. All the patients are agreed for it, so we can convert those type of the patient into the Medicare health plan.
That's great. That will be fantastic. Of course, you will own the patient, you own the insurance, and allow that. So
most people agreed for RPM, so we can tell them to join into this one. Most people are going to agree for it.
Yes. So Dr. Parikh, come on, take the stage. Unmute yourself. Dr. Parikh, unmute yourself.
Medicare Advantage.
Yeah.
Medicare ACO.
Okay. Can you hear me?
Yes.
Yeah.
Yeah, I'm all with it. So I will welcome this new health plan in Gwinnett County and North Fulton County.
No. You're not going to welcome. You want to create the plan. So you have we need to have a physician-owned Medicare Advantage plan. So it takes about a year to get the application going through. So this is the time where we invite all our physicians together and at least have an open discussion. Just imagine about 5-10 years ago, people would not even imagine a physician can own an insurance company. And somebody did it, and then, but this is since we have ACO being successful, and we now have learned a little bit about how the Medicare Advantage work. We're learning MRA, we're learning HIDUS, and learning, so we are getting ready ourselves to move towards a system which really very effective in reducing the cost and creating enough revenue for insurance company. So just imagine you as a owner of that insurance company will benefit by providing better care for the patient, maybe pay yourself a little bit more, and then save that money rather than somebody else getting their money. So anybody else want? Dr. Toby Bond, are you there?
Yes, I'm here.
Okay, Toby, what do you think about that? You leader in Clark County, so we can see enough physicians together, forget their differences, come back together. This is a great opportunity.
Oh, I don't understand the question. I mean,
No, no,
What's the
but what I'm saying, what are the possibility of getting the physician together, independent physician together in Athens, Clark, and Coney County to invite to create a Medicare Advantage plan?
I think it's a little early. You need to have something take shape first before you present it to them.
Okay.
I mean, I
Good.
know
So-
y'all are working on it, but you know, this is a couple year out project.
Okay.
And so I think when it gets a little closer, I mean, you can have a dinner. We can have a dinner and kind of explain it to them face to face and answer questions. But you know, you're in the conceptual stage right now.
Yeah.
And then if you do it too early, they'll lose interest. Those are my thoughts.
Okay. Very good.
So Dr. Bond, it's slightly different than that. Is the ACO network that you're a part of now has a relationship with Prominence Health Plan that has Medicare Advantage plans in 2 states. They also have a strategy where they believe that if they open a Medicare Advantage plan in a random area, it's very risky. But if they open a Medicare Advantage plan around an ACO with critical mass that includes a high volume amount of high quality PCPs, for example, like 50 per county, as well as PCPs that are willing to invest in their own company, they'll choose your county next. So Dr. Aggarwal has brought up, he's like, how can I be next on the list? Because Prominence is trying to figure out which county to come to next. And what I told Dr. Aggarwal is I said, it's your choice. Is if you can show Prominence that you're the next best network, you have the most high quality physicians as well as physicians that are willing to invest in their own MA plan, then you'll be next on the list. So the just question is now is, you know, can we knock it out of the park in 2020, get $10 million in shared savings, use that to attract another 30, 40 physicians per county, and then use that as an application to appeal to Prominence to come to your county next. And then you're going to be a powerhouse of independent physicians. You're not going to have just an MSO. You're going to have your whole darn Medicare Advantage plan. You skip the middleman. So it's remarkably different.
Well, we just need to set up a timeline and get organized and maybe start presenting this, you know, with people over dinner or something.
Hey,
I like dinner.
I mean, we can just invite, you know, 5 or 10 and, you know, so it's not too many. And then maybe another night next week, do 5 or 10 or something like that. And just take them to dinner and, you know, sit down and explain things to them. It's kind of hard. See, David, I just learned that you have a relationship with this Prominence company. So I didn't even know that. So, you know, you have to explain things to people.
So
You're way ahead of the rest of the doctors. So we need to catch them up. That's
Good.
all.
So Derek, I see you. What do you have anything to tell us or teach us, Derek?
Yes, hi, Dr. Aggarwal. I'm right here. I came on because I know that there was some MRA and Blue Sky HCC topics tonight. So when it comes to Medicare Advantage, I mean, this is right aligned. You know, HCCs and MRA. That's going to be the funding. That's how you get funded by a Medicare Advantage plan. So learn the stuff now, become experts at it now, and you'll be very successful into the future. All of this, the ACO is like training wheels for the Medicare Advantage plan.
Derek, can I just say that I only showed them the HCC Insights Report?
Sure, that's fine.
In the demo environment, and I did do the disclosure, but I do find that that's an extremely helpful tool. I'm not sure if everybody has access to that.
Everybody does.
It would be so helpful, especially in crunch time at the end of the year, to know where they stand.
Absolutely. So actually, we're going to distribute a paper report that has the dropping HCCs to all the practices in November, and that's an easy report for us to generate, so we can have that pretty soon next week. And then jump in Blue Sky. You know, doctors that are really successful with their risk scores, log into Blue Sky, pull up the patient and the HCC Insights. I'm not. I was stuck on a phone call. I couldn't join on time. But you may have already said this, but jump into the Blue Sky Analytics dropping HCC report, and then you can see right at the point of care, you can look up the patient and see if there's any conditions you want to address.
Yeah, Derek, or maybe somebody else. When you deliver that report, can they run the detailed report? My concern is the providers that are getting it on paper are not able to drill down and actually see which conditions each are dropping for each patient.
Yeah, there's two ways we can run it. Depends on what the ACO wants. Some ACOs, I give them the patient level, and then they look up the patient and get the details. I also have a way of generating the detail report, so you'll see each patient with a list of their dropping HCCs. Got to get them before the end of the year, and then you'll really be successful. Because remember, this is we can raise our risk score up to 3% in this enhanced track ACO, and that's worth $4.5 million to doctors ACO.
Exactly. Thanks, Derek.
Let me ask Dr. Peroni. Sophia Peroni, she's been very active in Doctors ACO. Sophia, can you get physicians together, primary care physicians together in Gwinnett County, just to learn about this program? Sophia, unmute yourself.
Dr. Aggarwal?
Yes, I can definitely try to do that, to reach out to some of the providers that I know.
That's great. If we get together, well, let me tell you, the reason doctors not able to take the lead in U.S. healthcare, and this is the reason. We just live in our own world and own clinic and do a great job and very satisfied what we do, and we save life. But time has changed, so we got to get together and let's see if we can do something different. Something hopefully we can get into the leadership role, and I believe that the healthcare should be governed by the physician, not by somebody else. So,
Dr. Aggarwal, this is Toby again. There are several Medicare Advantage plans in the area, and most of the doctors are participating in one or several. So first thing is they've been in it several years, are getting better each year, okay? Especially with the MA plans that are really engaged, like United. The Medicare plans like Aetna don't do it. So they understand the Medicare Advantage plans, and if they do well, they're already getting bonuses. So they're familiar with the concept. What you have to sell is that you're starting your own Medicare Advantage plan that they can invest in.
Correct. So
I mean, everybody's been working on it a couple of years, which saves us years of teaching people.
Toby, you're great. Let's start talking to people, and just like that, we started a Doctors ACO. Took a long time to convince enough people to come together, and I think we are at that stage where we really want to start the discussion and see if there's any fear or any concern, and then we can get some advice from our physician friends. And it goes county to county. If we can bring it Clark County. See if we can bring in Gwinnett County, which would be awesome. If we can bring somewhere in Columbus area, that will be also great. So we can bring it next year here. Maybe we can bring it somewhere in. I think Gwinnett County has a great chance too. It's a big county. You got a lot of independent physicians.
So the doctors that are engaged in these Medicare Advantage plans, I mean, I have a very lucrative contract with United, and I make a lot of money from them, so I'm already engaged. I already understand it. I'm already seeing benefits in revenue. I mean, significant revenue from being in a Medicare Advantage.
Or you can make money for yourself. So this is like a physician. Then you make the rule how the Advantage plan run. You decide what is the reimbursement going to be when you become the insurance company, and that's what physician need to do. Let's see, we have about 5 minutes. Anybody has anything across the board want to talk about? Any questions? Please raise your hand or unmute yourself and talk.
So Subodh, in Gwinnett County, if we want to do MA plan owned by physician, how much is going to be cost?
Good question. Let me tell you, the money is not the problem. We can raise the money. It will cost about $5 to $6 million base money, and then backup money will be out. So money is we will assure that money is not going to be a major issue. The major issue is getting physicians together and then training them to run the MRA program. Will that change your mind, Dr. Parikh, if we say the money is not the problem?
My mind was already set before, but this really helps me.
Oh, that's great. Very good. Fantastic. I think Dr. Parikh, you a leader, you just get into start calling people and let's see if we can get together. That's the way it started. That's the way things started. And Dr. Arthur, he's been working for 5 years. It took 5 years for him to put things together. So I'm not expecting that everybody going to jump on it and we're going to start doing this tomorrow. So we just, if you meet somebody, talk to them about it, and then hopefully again come back to this forum again in 2 weeks, and maybe we'll have more people on it. But that will be, I would love to see that we tell the hospital and we tell the the doctor tell the decision, how much and what we can do for patient, not the other insurance company.
So in Gwinnett County, Subodh, so let Dr. Safia Pirani take the lead.
Safia, would you help us? I mean, I think she can do it. She has a lot of energy. I'm really impressed with her, the way she runs the operation. She has 4 clinics, and she does very great work for that county. So I think what Safia can do, he can call the leaders like Dr. Podar, Dr. JJ Shah, and do you have any other names? We already have Dr. Parikh, so we can get together and start from there.
And Dr. Donawali?
Dr. Donawali, yes. That's great. Dr. Donawali, you can call Dr. Shah, or just call everybody and see we can meet together, even for 5 minutes. We just say, hey, I'm ready.
Okay, we can try doing that.
Yeah, that's very good. So let's see, we are almost ready to go. 2 more minutes to go. So if everybody, let me tell you, if you are doctor's ACO physician or work for a physician who is doctor's ACO, make sure your attendance is noted, and please let your consultant know. And so we all these attendance on this forum will be awarded. And thank David, his hard work. We able to save some money, and that money will be distributed among the people who attending, learning, and advancing the cause of Doctors ACO. So thank you all. Thank you, Carrie. Thank you, David. Thank you, Dr. Parikh and Dr. Toby Bond and Dr. Safia coming up and participating in the talk. Derek, thank you. We meet again in 2 weeks. And hopefully we'll talk a little bit more about the Medicare Advantage plan owned by